Hello, everyone, and welcome to Mobile's Role in Population Health Management, sponsored by PerfectServe. I'm Evan Sweeney. I'm a senior editor at Fierce Healthcare, and I'll be moderating this webinar. Our speakers today are Jeremy Rogers. He's the director of eHealth at Indiana University Health, and Darren Olson. He's the director of consumer innovation at UPMC Health Plan. Also, we have Michelle McCleary. She's a vice president of product management at PerfectServe. You can read their full bios on the right side of your window. Just a few technical notes before we begin. If you have trouble reading a slide, please hold and drag the right corner of the slide window to enlarge. Please also disable your pop-up blocker to participate in the interactive parts of the presentation. If you'd like to download the slide deck, please click the Resources button at the bottom of your screen. This webinar is being recorded and will be available on demand within 24 hours of the event. We will follow the presentations with a Q&A session. Please submit your questions during and after the presentation using the purple Q&A widget at the bottom of your screen. Okay, now let's begin. Jeremy, you can please go ahead.
Thanks, Evan. Happy to join you today. Today I'll share a brief overview of our organization, provide a bit of context on various customer-facing mobile initiatives we've done over the years, and then go through an informal orthopedics joint replacement case study. Before wrapping up, I'll also review a few lessons learned and preview some mobile strategy work that we're doing to enhance our approach going forward. As Evan mentioned, we should have time for Q&A after the presentation, so please feel free to submit your questions along the way. With that, let's get started. Indiana University Health is a non-for-profit hospital system created in '97 with hospital roots reaching back to the early 1900s. IU Health is Indiana's most comprehensive healthcare system and one of the busiest hospital systems in the U.S. Through a partnership with the IU School of Medicine, one of the nation's largest medical schools and a global leader in medical education and research, IU Health is uniquely positioned to provide leading-edge care and highly skilled clinical teams. Across the organization, IU Health has more than 25,000 full-time team members and generated more than $6.2 billion in total revenue during 2016. IU Health's vision is to lead the transformation of healthcare through quality, innovation, and education and make Indiana one of our nation's healthiest states. IU Health's footprint across Indiana includes 15 hospitals and hundreds of primary care, specialty care, and outpatient centers, offering a full range of services for both adults and children. IU Health was named to the top hospital system in Indiana, included among the nation's top hospitals for the 19th consecutive year in the 2016 Best Hospital Rankings by U.S. News & World Report. IU Health is also among an elite group of hospitals with magnet designation for excellence in nursing services and clinical outcomes. With that background in our organization, let's explore some of the ways we've leveraged mobile solutions to aid population health management. IU Health launched our first mobile app more than 5 years ago. Since that time, several apps have been launched, relaunched, and retired with varying degrees of success and using a variety of different delivery models. Many have been externally developed custom for IU Health. Others have been off-the-shelf apps white-labeled or co-branded by a partner, and a few have been custom developed in-house for a specific audience, facility, or service line. Today, we have more than half a dozen apps available to consumers covering several standard use cases. Those include things like wayfinding, provider directories, referral management, patient education, telehealth, wellness, and we even have one that includes train schedules for our People Mover monorail system in downtown Indianapolis. Now let's dig into a case study for one of those apps targeted at our orthopedic service line, specifically for hip and knee replacements. For several years, as patients across our system were scheduled for total joint replacement surgery, they have been handed this substantial binder. It contains nearly 100 pages covering a joint replacement overview, surgical prep details, discharge instructions, activity and exercise guidelines, care team contacts, and other general information. As with any printed material, there are limitations on what information can be included in the binder, and making changes at scale can be both time-consuming and costly. It can also be challenging to measure patient utilization or satisfaction with the binder. In 2015, an idea was floated to digitize this experience for a couple of primary reasons. Number one, to enhance and extend the patient education offerings the binder includes. And number two, to address CMS Comprehensive Care for Joint Replacement, aka CJR, bundle payment model requirements to submit patient patient-reported outcomes on a regular basis. Through late 2015 and the first half of 2016, we sourced funding, gathered business requirements, and planned the launch of a mobile app to address this need. After several rounds of internal testing, the app was soft launched in Q3 of last year with a core set of functionality. A large portion of the app's content and functionality are focused on the key patient education piece. Unlike the printed binder that can only be offered with static text, images, and diagrams, the app includes a wider variety of education options. We've included all the materials available in the binder, reformatted for the mobile format, plus added several interactive elements as well as a series of embedded videos recorded by our care teams. These education options are included throughout the user's timeline, and they always have the ability to go back and review previous items. In addition, they can bookmark specific items or share them externally with their family or other caregivers. In addition to education, pre- and post-operative timelines include key milestones along the way. Users have the ability to track their progress leading up to surgery with task lists, reminders, and other important instructions from their care team. They can also visualize those timelines to see any tasks they may have missed along the way or to preview what's ahead. Another core functionality of the app is the ability to trigger scheduled patient-reported outcome surveys. As I mentioned earlier, measuring and reporting such PRO data is a component of the overall CJR bundled program. In this case, we've implemented PRO measures using the WHO's and COO's questionnaires for respective hip and knee replacement patients. As specific milestones are reached on their personal timelines, users receive alerts to complete pre- and post-surgical function assessment surveys. The submitted data is then accessible to care teams for follow-up and subsequent reporting, typically 90 days post-discharge. Beyond the end-user experience within the app, there's a back-office console that office staff and clinic employees leverage to trigger user invitations and handle other user administrative tasks. As patients are scheduled for surgery in certain locations, they are offered the app as an option alternative to the printed binder. At this point, we've chosen to not pursue EMR integration of this workflow. So office staff are manually triggering the invites to patients. In addition to those core features of functionality, the app includes several additional options. These include push notifications for timeline alerts and reminders, secure outbound messages from the care team to the app users, care team profiles, contact information, and on-call schedules, and things like exercise and physical activity tracking, including Fitbit, HealthKit, and Google Fit integration. So in Q3 of last year, after the app was deployed, we soft launched at one of our suburban hospitals in Indianapolis. That included staff training for the office staff, internal communications to the care teams and providers, and a series of patient-facing collateral. At first, it was only offered to select patients. What you see here is an example of a tear pad that was used in the office to invite patients. So once the invite was given, the patient was given a secure authorization code, instructions to download the app, and to log in for the first time. So in terms of lessons learned with the rollout so far, there are a few key things I'd like to share with you. Number one, we found that operational support was critical. Regardless of the technology or user experience you've implemented, without proper operations to invite users, handle frontline inquiries, or troubleshoot questions, your efforts may not resonate. On the content side, don't assume you can just copy and paste the same assets you have from print to other channels. Mobile experience may require more short-form content or new interactive elements. As I mentioned, with a 100-page binder to digitize, some of that content did not translate properly. We had to reformat, truncate in some areas, extend in other areas to make it more engaging for patients. Number three, don't assume you understand the potential users of your solution. In our case, there were some early assumptions that the app adoption would be consistent across all of our patients, but that's not been the case. We quickly discovered that some patients simply prefer a printed binder even if the app is offered to them. In other cases, they may really adopt and quickly engage with the app. It was highly variable. Number four, which also speaks to patient outreach and engagement, one area where we fell flat. Your solution may require more TLC up front to get users registered or even to download an app. What type of outreach can you put in place for users who have never logged in or abandoned at some point along the way? So it can't be if you build it, they will come. You have to have an outreach program to make sure that the patients actually understand how to leverage the app, basic technical support, frontline, things like that. And finally, and probably one of the key lessons learned for us is really what are your KPIs? In our case, we had an initial business case for a trial launch, but we didn't clearly define what the milestones would be for further expansion along the way. So you need to really have objective, quantifiable measures to truly understand what success looks like. So now I'd like to transition away from lessons learned and really talk about how we're going to take this moving forward. So today, IU Health doesn't really have a formal process for the intake and vetting of mobile application project requests. The absence of a central governance process inhibits our ability to deliver high-quality mobile initiatives in certain cases, determine which mobile projects requests align with our strategic goals, and reduce time to market from ideation to delivery. As part of a mobile governance model, we're creating a playbook to support different phases of the mobile app lifecycle. The playbook will serve as a high-level, repeatable delivery accelerator for future mobile projects. It will be a flexible living document that includes a variety of resources. It will cover at high level things like ideation and requirements gathering, helping folks across our system, clinicians and other business users, to truly vet out their ideas to understand how they may connect with our patient populations, where they may be successful or less successful in certain areas. It will include an inventory of templates for key deliverables, things like requirements gathering, project plans, key resources required to really help them jumpstart their planning efforts. It will include typical project milestones and those core team members that are required for a typical project. And at a central level, it'll be an intake workflow to guide users through the evaluation of mobile app requests. Perhaps develop decision tree documentation with specific criteria for evaluating the different requests that we have, how we prioritize them, and stack rank them in some cases. The criteria will include things like business value, technical decision making, and milestones for approval. And then ideally an objective way to define project evaluation and selection process. Ultimately, the goal is not to inhibit or stymie these new ideas, but create more of a repeatable process so we can intake the ideas, determine which ones may truly require a mobile solution versus those that might not, and really help supercharge that going forward. So with that, I want to thank you for your time, and please remind you to submit any questions you have for the Q&A session later. I'd now like to hand it over to Darren. Thank you.
Hi, this is Darren Olson with UPMC Health Plan. I'm the Senior Director for Consumer Innovation. We are primarily in Western Pennsylvania, and we occupy an interesting space in that we are an integrated delivery and finance system, which means that, as most of you probably know, that we have a healthcare delivery system, but we're also an insurer. But what makes things especially interesting for us is that we are not a closed system. So on our health plan side, roughly 50% of our members don't go to our facilities. And on our care provision side, about 70% of our patients do not have UPMC health insurance. So some of that's going to come out in this in the presentation, in that we are engaging in telemedicine and more specifically in the remote monitoring program. It's a cross-organizational initiative, so we get to have fun sort of juggling the various interests of each side of the business. So we have launched an overall telemedicine initiative essentially starting close to 10 years ago. And with digital engagement, with incentive programs, about 5 years ago, we launched our first telehealth urgent care program, and our mobile apps as well. Just recently, we've been moving forward with digitizing our lifestyle improvement programs. And to echo the previous presenter, on those lessons learned, I think every single one of those is absolutely critical. I 100% agree. And learning who your audience is, because technology is not a solution, and it never will be. And digital is not a different type of care. As long as we're thinking about things in those silos like remote monitoring versus telehealth versus e-visits versus, we're going to alienate our members. And if we do that, in cases where no one wants to engage with healthcare anyway, we're just putting up more barriers. So in that vein, my personal focus at the health plan is around consumer engagement. And key for engagement is usability and convenience. So when we're looking at a remote monitoring program, we're not looking at it in isolation. We're looking at it, how does it fit into the entire ecosystem from a consumer's perspective so that it's usable, it's understandable, it's convenient, and it's relevant. And so I think that's going to be one of the key messages throughout here that we have to understand and remember, which is technology is not a solution. It can be used to help to develop solutions or help to augment current care paths. So along those lines, what I'm going to talk about here first is what remote monitoring is, which is, I'm going to go over this pretty quickly because I'm pretty sure that that's a pretty well understood concept with this this group. But the components of remote monitoring is something that we actually had to, 5 years ago, I believe now, when we first started looking into this in earnest, we had to develop a lot of these paradigms and how we were looking at the field of remote monitoring, in particular because we were evaluating many different vendors or different technologies, and everyone was approaching it from a different perspective. So we had to create our own methodologies. And what that is centralized operations, call centers for alerts so that the data goes somewhere and that the data is also actionable. The care management platform, which allows our staff to triage through that information. And then the other piece of this, of course, is what is the technology that's going to allow our members and also our employees to engage with this program in the easiest manner possible. So our initial experience here is that we've got technology with tablets and peripherals. The IT audit and healthcare IT systems are critical. This is a failure is not an option scenario. Then also the financial modeling, which I'll go into in a little bit later, in particular around the fact that traditionally health insurance companies and health systems have vastly different and sometimes opposing financial models. Then one of the biggest pieces overall of remote monitoring is operations, which is the kit logistics. It's the devil's in the details. We have an internal system that helps us with distribution. And then the last piece is the use case. And use case is both along the lines of the conditions that we want to cover, but also just as importantly along the lines of a patient's acceptance of this. Especially if they're viewing this as a health plan offering, you need to make sure that there is that level of trust there that not only enables patients to accept this type of solution, but also to engage with it on a regular basis. So The overall timeline, I'm not going to go too much into detail here, but the overall timeline for our remote monitoring program, we initially started doing remote monitoring in 2008, and then went through a lot of iterations. Like the previous caller said, we learned a lot from it. In particular, at that time and even now, it's somewhat of a Wild West environment where we got to forge our own path. So we've been doing that over the last 9 years or so. We started off with congestive heart failure, and one of the reasons there clearly is that while there might be a lower volume, each individual case that we can prevent readmission for has a really high ROI. And when we're looking at the care path of providing equipment, especially specialized equipment, to our members, we need to make sure that there is that value proposition there. So we need to match up the level of service that we provide with the value proposition for each of those conditions that we cover. After congestive heart failure go live in June of 2016, that was, by the way, our third iteration of the CHF program, which began in 2008. So this was our third go live, and one that we feel is exactly in the right direction. After that, a couple months later in August, we went live with advanced illness care, and with the intent there of keeping people in their homes longer if they're on palliative care. Then we moved on to a completely different type of remote monitoring with tobacco treatment services, and that was our first foray into the bring your own device market. And there are a few slides on that in a little bit. And then in April, we went live with irritable bowel disorder, and I have some specifics on that as well. So on the congestive heart failure, we wrap in a number of peripherals that we provide in the kits that I had mentioned, along with a digital input system for the members. When we moved on to advanced illness care, that's primarily a tablet-based program, but again, these are devices that we provide to our members. And when we start looking at things like irritable bowel disease and tobacco treatment, with tobacco treatment in particular, the approach that we took there is the bring your own device, clearly sending out hundreds of dollars of equipment to every smoker in the hopes that they would quit smoking. That's a difficult value proposition and return on investment. So patients currently under treatment for chronic IBD conditions, there's a remote monitoring call center. Patients are monitored by that call center specifically for high alerts or red alerts. And then on the second level, the yellow alerts are then sent to the IBD clinical staff for follow-up. So we can triage and respond based on the level of acuity that we determine from our algorithms. And of course, the goal is to avoid hospitalization and to control symptoms remotely. Part of that is also reduction of narcotic usage, and that's done through education via call center. Also, we have the ability to push on-demand videos. And then behavioral stability, as we all know, behavioral disorders is the most common comorbidity. So we're using the system to allow for connectedness with clinic and call centers. So the tobacco treatment services are available for patients who are currently smoking and have been discharged from the hospital. They use their own smartphone to answer a questionnaire. There's branch logic that understands patients' current usage of tobacco, but also, just as importantly, their willingness to quit. The ability to push out informational links, again, similar to the IBD program, and clearly with something like tobacco treatment services, we're using the system for a less expensive and quickly scalable program to the desired patient population. And that's less expensive not just from remote monitoring where we provide any hardware devices, but also from the health coaching that we currently provide, which is a one-on-one health coaching, or the booklets that we send out, or any of the other programs that we have. And the goal is to provide tobacco cessation programs per CMS guidelines, collect the data to see who is reducing smoking post-discharge, and then the ability to properly target outreach. So again, multiple approaches to connect with patients. We can have different methods and goals for program usage, including to the research for the data collection, early warning, early interventions, follow-up after hospitalizations, also reminders for appointments or tests, and then the outcomes that we're pushing for, of course, are reductions of hospitalizations, but also of ED visits, increase in medication and discharge instruction adherence, as well as on-demand education pushed to the tablet or the BYOD device. So why remote monitoring? Slides are catching up here. All right, I'm not sure if this image is coming through. It's not showing on my screen here, but one of the medical director who oversees our remote monitoring program, one of his favorite analogies around remote monitoring is the air traffic control tower. So as we're thinking about the different conditions that we're covering or looking to cover, like congestive heart failure, diabetes mellitus, hypertension, all of those things, we can't look at them in isolation, just like we can't treat patients in silos. So what we're looking to do with remote monitoring, but even larger than that with telemedicine, and I should say not that we're looking to do, it's that it is critical that we approach this in a consolidated manner so that the overall ecosystem and experience for the member themselves is just that we are providing care to them, to help them stay healthier, to help them stay out of the hospital, and engage with our various health resources. So then on to why remote monitoring. I mentioned this before, but we've got reduced costly readmissions. We have shown a decrease in readmissions of approximately 12 to 15%. We're steering patients to the appropriate levels of care, but also only when necessary. And then to tailor care to the patient's specific needs, it allows for personalization. And then branching logic, which there's a little bit on branching logic in a few slides, but whether it's daily, weekly, biweekly questionnaires, on-demand video calls, and most importantly, that the patient still feels connected to our overall, the UPMC ecosystem. So the basic overall process here is initial triage and enrollment, and we have logic which determines, like for the tobacco cessation program, who can get enrolled, but then also what pathway do we go down. So for the 5% or so of the highest cost patients, we will push out kits, peripherals. It's expensive, but it also has a really good ROI. Whereas with the 95% where they need a little bit of help or they need just help managing themselves in their own care, we can send them down the self-directed pathway through BYOD. All of this leading, importantly, to graduation from the programs themselves. They are not intended to be programs that are engaged in perpetuity with each individual member or patient. And I should say, I keep saying member. That's because I work on the health plan side, but this is also available across the entire system to our patients as well. So our call center. There are three pieces: clinical, which is the doctor referral process, pre-kit shipment calls, the enrollment calls, alert management, the social work activities, including prescriptions, any travel, as the previous caller had mentioned as well, that's something that they are tackling, appointments, and then non-clinical from the call center perspective, like kit issues, kit logistics. We found early on when we deployed that there were a higher number of non-used kits that we had sent out than expected. And so we quickly found out, obviously, it's not just a clinical issue here. It's also how do we fit this into the life workflow of each of the recipients of the kits. And then the hardware, software side of things, Genesis, our call center software, documentation, integration into our EHRs, so that, again, it is part of the overall care of UPMC rather than a completely different type of care. So with the program that we have, what the program allows for, which I think is very, very important and we've found to be incredibly helpful, is that we have a 100% customizable pathway creation and design. And we can make that according to time and frequency. So depending on which care pathway that we're designing or developing, depending on the type of patient that's going through, we have the ability for operational and clinical leads to have full autonomy for creating patient care plans, to customize the time that care plans are active for patients, utilize remote monitoring call center, and then the kits designed around program specifications, again, with the need for whether it's BYOD or glucometers or scales or things like that. So here's an example of the survey design inside of the CHF CHF pathway. So here we can not only customize what each of the survey questions are, but then also, depending on what answer is provided, we can then shift them into a yellow alert or red alert, which then cascades the actions that I discussed before, whether it's outreach from the call center or more of a delayed outreach from our clinical folks. And again, our medical director, Dr. Andrew Watson, really emphasizes the fact that in terms of the implementation effort, technology is important, certainly. Finance is also important, but the vast majority of the effort is in operations. It's in the clinical, the non-clinical, building the care pathways, et cetera, that cannot be underestimated. That effort cannot be underestimated. So then some specifics on our video visits here. This is showing since the inception of our new platform in June of 2016. We have incorporated patient video visits as a core piece of the care pathway as well. And then in terms of patient volumes of health plan versus non-health plan, you can see that on the health plan side, which we do have a centralized care management group, which allows us to leverage programs like this. You can see the patient volumes there. Then in terms of outcomes, So this is just finishing up here, and then we can open it up for Q&A. One of the things that I mentioned earlier was the health plan versus non-health plan. And if our goal from a clinical benefit and operational outcome perspective is to have cost avoidance from the health plan side, that is going to affect the utilization on the non-health plan side. And it's not that we're trying to, by any means, drive people to our facilities when unnecessary, but it's figuring out really that is a core issue to be dealt with when looking at something for an IDFS of how do you balance those benefits across the entire system. And we've been able to get solid buy-in from both the health plan and the health system side. And one of the ways of doing that certainly is that the risk share is shifting over to the health system as well for proper utilization, both from a commercial perspective as well as from a governmental program perspective. So it's looking at that, getting buy-in across the system from the PCPs, from the hospital system in general, as well as the finance side of the organization. So that concludes the presentation on my end, and I'll, I guess, turn it back over to Amy or Evan.
Yep, real quickly, before we get to the Q&A portion of the presentation, Michelle McCleary, who's with PerfectServe, is going to talk for a few minutes. Michelle?
Thank you, Evan. One of the primary components of an effective, comprehensive population health management strategy is the development of key relationships across different providers, so not just hospitals, but also with practices, post-acute care facilities, and other organizations, as well as with payers and community health organizations. Because fundamental to the success of any strategy is the ability to easily and quickly communicate and collaborate across the continuum and all the stakeholders. And this is the only way to ensure that you will provide episodic care management and the appropriate level of care, as well as to effectively and efficiently manage transitions and referrals, so movement between different providers as well as different levels of care. In addition, it's important that the entire care team, wherever they are located, to be aware of any unplanned admissions or ED visits, for example. So if it were possible to be able to easily connect the ED physician with the patient's PCP and maybe home health provider, then that would be key to preventing any needless hospitalization or a readmission. Further, the partnership with community health organizations will allow healthcare organizations to develop and launch different community health initiatives, such as smoking cessation or improved nutrition. And finally, and very key, of course, to effectiveness is the need to engage the patient and family as an active care team member. Market analysts and healthcare leaders concur that the execution of a successful population health management strategy will require innovative technology beyond that of the EHR. Illustrative of this is technology to enable and expedite communication and collaboration across stakeholders. And such technology, of course, must provide bidirectional exchange of patient information while protecting the same. But more importantly, it will need to accommodate your mobile providers, those who move between facilities or even patient locations, as well as those who may be stationary in one facility. Further, it must do this in a way that eases and accelerates communication, versus the traditional standard methods. I search for who to contact, I pick up the phone, and then I leave a message or wait on hold and wait until somebody else reaches back to me. Because we know that that doesn't work. If you view the graphic on the right-hand side of this slide, you also see two other key capabilities of the needed communication technology to really support your population health management effort. First, that technology must be multimodal to provide all stakeholders to communicate how they need at any given time. So we've mentioned mobile. So mobile devices are key, and the ability to securely text to exchange brief information will be able to do so without needless disruption is also of value. But if I'm a stakeholder and I am working in front of a computer or have easy access to a computer, I don't want to have to reach into my pocket to grab my phone. Instead, I want to be able to communicate and collaborate through a web application. And if I were traveling from site to site, it may be necessary for me to communicate via a secure voice message. So I'm not taking the time and distraction to type in a message. Also, it's necessary to have telephone access. If we think about those older, possibly homebound patients, they may not have access to a mobile device. So we want to make sure that they're able to quickly communicate and connect as well. In addition, real-time video conferencing capability will allow quick consults and collaboration to confer with your colleagues, as well as patient checkups and any type of monitoring. The other key capability is that the communication technology must easily extend across all disciplines and roles, as well as multiple facilities. So you can see population health management in terms of technology is located in the right upper quadrant. But let's say, for example, you had a physician practice who had a text messaging solution, but only within their practice. Obviously, that's not going to support the needed communication and collaboration efforts required. And PerfectServe, I'm sorry, I'm having difficulty with the slides as well. And PerfectServe has these capabilities. It offers a secure care team collaboration solution that is able to facilitate patient-centered, timely collaboration across all care team members and care settings. And the way that this occurs is through two distinct capabilities. First is dynamic intelligent routing. So rather than having to struggle and search and determine who to contact and leave messages, instead, PerfectServe provides tailored algorithms for every communication situation. So at the time of communication, then PerfectServe will analyze all of the situational variables in real time. And so rather than looking and searching for information, instead I am automatically connected to the correct person. The second capability that is distinct and important is that PerfectServe is a single multimodal cloud-based architecture. So that allows the dynamic intelligent routing to easily extend across all facilities and all care team members. In addition, it provides patient-centered routing. So as your care team is distributed across different sites, and as the care team may fluctuate depending on the patient's needs, so there may be care team members who are static, but others who are quite dynamic, just depending on the necessary care. Well, this makes sure that your communication isn't centered around a facility or provider. Rather, it's centered around the patient, and that's how the care team is connected. And with the cloud-based architecture, that truly can overcome the geographical boundaries and the entrenched hierarchical barriers that are long-standing within healthcare in terms of communicating across all different roles. So PerfectServe is able to facilitate collaboration across all care team members and care settings, and making sure that communication collaboration centers around the facility. And it's really only in that way, by easing communication and collaboration and automating much of the effort, that population health management objectives will be accomplished. And I will turn it back over to you, Evan.
Thanks, Michelle. Now we're going to move on to the Q&A portion of the presentation. There's still time to submit your questions using the Q&A widget at the bottom of your screen. We already have quite a few questions that came in, so we're going to try and get to as many as possible. But I'm going to start here with you, Darren. We had a question that came in. Is your call center 24/7, and does your CHF program include home visiting nursing?
Yeah, hi. Sorry about that. All right, so there are no right now they are not 24/7. The eventual goal is to be 24/7. But we only send pathways Monday through Friday during the morning to the patient. So even if the patient is late, staff is there. And there is weekend coverage in case someone requests a call. There is someone to initiate that. But the eventual goal is to be 24/7.
Okay. And is there home visiting nursing?
There is, yes. So we have, on both the health system and health plan side, we have visiting nurses. That's been the case for a while now, and we're just linking that up with the monitoring program.
I see. While we're talking about that CHF program, does it send key performance indicators to your analytics?
Yes. So for two purposes, there is both along the lines of looking at performance as well as adjusting care pathways as needed. So I think that question was probably more to the first piece. So yes, we do send KPIs.
Okay. This question is for Jeremy. Are analytics a part of your orthopedics patient engagement app? And do these analytics interface and integrate with enterprise analytics?
Yeah, great question, Evan. So the answer is yes. So there are analytics. There's actually a whole dashboard behind patient engagement that we're assigning scoring to individual patients based upon their engagement, where they are in their pathways. And then on the second part of the question, do we have those integrated into our enterprise data warehouse? The answer is no, not yet. It's a roadmap item, but we're not there yet.
Okay. And another question for you, Jeremy. What were the best practices to promote mobile adoption? I'm assuming this is among patients.
Yeah, I would say we probably haven't cracked the code on that one yet. I would say a couple of high-level things. One is to give users the ability to trial or demo. So if you have the ability to actually have people walk them through, even if they're non-clinicians, if it's office staff or other more of a retail environment, to give folks an exposure to the app, more hands-on. And then, as I mentioned in the presentation, if you can make sure to have that follow-up with the patient, so don't just give them a link or download the app for them and then walk away. If they have questions, there needs to be sort of a recurring follow-up or an engagement or outreach program to make sure they are actually adopting and leveraging the mobile solution.
Mm-hmm. This is a question for Darren. How did you work to change patient behavior with the unused kits? How did you get them to kind of take control of their own health?
So, you know, we're not going to be obviously changing behavior of people who don't want to engage. It's either getting them to want to engage, which is through educational materials, but also what's kind of funny is the primary cause for the unused kits was that we found out that people couldn't figure out how to turn the kits on. That the equipment that we were sending out was maybe not as intuitive as we thought that they should, that we thought that they were, but also the instructional materials weren't as straightforward. So we did a lot of testing and shadowing to determine that, okay, what are the key barriers to engagement? And that was one of the pieces that was critical. But again, the other piece is through education and just ensuring that people understand why we're doing what we're doing, and building that level of trust with them that we're really looking out for their best interest.
Mm-hmm. Also for Darren, how are you driving content to members based on the outcomes of their test or their outcomes?
Yeah, so we're still in the process of figuring out the analysis process of the outcomes, but sort of like Jeremy was indicating, and like I mentioned before, there's a lot of work in process right now, but the algorithms themselves are very easily modifiable. So, for example, if you remember that screen that was on that showed the pathway, if someone chose a certain answer, like do you feel like you're having trouble, quitting smoking, or do you have an urge right now? And they say yes on a scale of 1 to 10, it's 10. We're able to attach specific materials or care pathways based on what it is that they indicate. That's also possible to do from automatically generated data like vital signs. But as far as the outcomes of their tests, we have a group called the Department of Health Economics and Finance that are working together to study those outcomes, look at the normal paths to certain answers, and identify where there are best opportunities to engage with people based both on the outcomes but also based on their willingness to change.
Mm-hmm. This is kind of a related question, and it's probably both of you can answer, but I'll start with you, Darren, since we're kind of talking about it. How do you address the elderly and the lack of internet access or expertise? I think you kind of touched on it a little bit with the kits, but they often need care the most, but are least likely to embrace technology.
Yeah, so I mean, a couple things. One is that I will say that there is less of a barrier. Increasingly, there is less of a barrier for adoption of technology in the quote-unquote elderly. However, right now, if the average age of participants is 74, and what we've had to determine for now, until we have a better solution, is that no internet means no participation, at least in the remote monitoring program. Now, this is not something like, hey, you don't have internet, we're kicking you out of UPMC overall. We have other methods in place, but because of the requirement of technology, right now for remote monitoring, that internet's a requirement, and we're looking at ways of adding in internet connection when necessary, or Wi-Fi, for, in particular, the top spends.
Mm-hmm. Jeremy, I'm going to put the same question to you. Did you guys run into that? I mean, is that something you had to address in terms of the elderly population?
Yeah, we did. I think in many ways I would echo Darren. So I think for us specifically, the use case I shared on the joint replacement use case, that's unique because those patients generally are more elderly. So that was definitely a nuance there. I think overall, though, even in our most rural areas, smartphone adoption is very, very high. Internet access is very, very high, so we don't typically see that being an issue for any of our populations. I will say, as we look at more mobile-specific use cases, we're not going mobile only, like Darren mentioned. I think we're going mobile first in more of the new sort of emerging areas, but there would always be a fallback. So folks who don't want to download an app, don't have internet connection, you have to have a fallback approach to serve them as well.
Okay. Is that a common reaction among an elderly population, that they would rather take the binder instead?
No, I mean, I think it's hard to lump everyone together. So I think looking at all of our digital solutions, mobile, non-mobile, we have very elderly patients in the 90s, for example, who love to use our portals, love to use our websites. But I think having a one-throat approach or having a standard solution there probably isn't ever going to work.
Mm-hmm. Another question here that both of you can probably weigh in on. Do you track or query the patient about non-clinical risk factors that could cause a readmission post-discharge besides the patient needing education? So is there anything outside of that? Jeremy, maybe you can start.
Yeah, I think I mentioned the WHO's and COO's surveys that are specific to the CGR program. So some other questions there are just around how they're feeling. I mean, they're not really non-clinical, but they're not surgical specific. They're more about their general health and well-being, and those go into the engagement score I mentioned. So if a patient answers questions or gives feedback a certain way, they may dip below a threshold and require either service recovery or some follow-up from their care team. Absolutely.
Mm-hmm. And Darren, anything to add on that? Is there anything you track or query in terms of non-clinical risk factors that might cause a readmission?
Yeah, we do. Now, from the remote monitoring perspective, we don't have that in our care pathways at this point. But in our general, care management, utilization management, we do use social determinants of risk. We're also getting into the LTSS space where we're going to be providing some of those services in addition to the healthcare space. But honestly, how that all fits into specifically remote monitoring, that's TBD.
Okay.
That is an absolutely critical question and that's a great question. That's something that we have identified that we need to solve for.
Right. This question came in. It might be a little technical, but I'll start with you, Darren. What service level agreement requirements are in place with with an internet service provider for monitoring acutely ill patients? Are there any redundancies in place?
So, I'll give you a little bit of a vague answer on that. We have an SLA specifically with one vendor that then manages any requirements for uptime or response time. So that's part of our relationship, but we do not specifically go to any ISPs and directly maintain any SLAs with them.
Okay. Here's a question both of you can address, and I'm sure many people are wondering, how do you get paid for these services? Darren, is that a factor?
Yeah, so we have, we currently, we're still working on the revenue model there, but billing for telehealth is really tricky. And it's something that not only from a operational perspective, but from a government perspective, from a regulatory perspective, what we do is, in general, we use our own clinicians. So our health system side and our healthcare providers are being reimbursed by our health plan. So that's also, I hate to sound like a broken record here in terms of, we're working through it. Still working on how to implement it, and what we're looking at right now, rather than focusing specifically on a profit-driven initiative, we're trying to work out the kinks here so we can have a smooth running machine that's profit neutral, revenue neutral, but that we can then build out and incorporate into the rest of our care pathways.
Mm-hmm. Jeremy, what about you guys? Is this a consideration or something that you've had to address how you get paid for these services?
Yeah, it is a consideration. I think we're in the exact same boat as Darren on many of those fronts. I think specifically for the ortho solution I mentioned, I talked about the CGR bundled payment. So the patient-reported outcomes, a component of that is you do get a bonus in that bundled payment if you provide those outcomes in a timely fashion over a certain threshold. So that was part of the business case, was if we can improve the adherence or the reporting of that data, there may be a financial benefit as well.
Mm-hmm. We get time for one last question. There were a lot of great questions today, but we couldn't get to all of them. We'll definitely get back to everyone who submitted personally after the webinar. But I'll just end on this, and maybe you guys can just give one issue or barrier that you ran into while rolling these programs out that maybe surprised you or you didn't expect. And Jeremy, I'll start with you.
Yeah, I think for us it was the patient engagement I talked about and the lessons learned. Also, it's really rolling it out at scale. So we started with one specific location, but we're a fairly large health system, and I think not having a sort of well-defined model of how we would take this across our entire system really stymied our efforts. So we could have done a better job of defining what that rollout would be, either do a big bang or clearly defined scope. That was probably the number one takeaway I had.
Mm-hmm. And Darren, any particular issue or barrier that you guys ran into that might have been surprising?
Yeah, I think, like I mentioned, with Andrew Watson had talked about operations being one of the critical pieces to figure, or maybe even the critical piece. Kit logistics was a big surprise for us, that there was a huge gap of steps in terms of, what are we thinking about, transportation companies and arranging things with UPS and figuring out how to store, how to clean, how to retrieve, like those. It's very much logistical, but we were more focused on the clinical side of things until we got into the operational side and determined that there's a lot there that you have to learn. Right.
Well, thanks to everyone, and thanks for our participants for attending the Fierce Markets webinar and submitting so many great questions. I'd like to thank our speakers for their input on this and for participating, and PerfectServe for sponsoring today's webinar. This webinar has been recorded. You'll be able to access the recording within 24 hours on the same page you used to register for this event. Thanks again, everyone, for joining, and we look forward to seeing you at future events.
Thank you.
Thank you.